Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
So traditional lasers, when we treated, we would essentially have a zone of ablation, and depending on the amount of absorption, we would have a zone of what's called the residual thermal damage. Many years ago, there was a discussion about erbium versus CO2. We know because there's less absorption with CO2, you actually get a greater zone of residual thermal damage. That means when you do those treatments, you're not going to see a lot of bleeding, but you're going to see a little bit of a serous ooze. And the wound healing happens from the edges and also the pilosebaceous units. And normally, when you do fully ablative resurfacing, can take about 7 days or so to reepithelialize. Now, there's a lot of variations in patient healing, but the whole purpose of fractional lasers is to take advantage of the normal skin surrounding those zones, whether it was ablative or non-ablative. And that's why it's so important when you're doing treatment not to cause that bulk heating. And I think that's why I often will touch the patient's skin when I'm doing the treatment. There's stamping modality, there's normal, scanning modality, and then there's intelligent optical scanning, which will look at the movement and lay down the zones. And so you can see here that this is using like a 1540, you can use a 1470 or 1440 diode as well, and you can just coagulate the tissue. When you have non-ablative lasers, and we did this actually with OCT, you have about a 24-hour time period where you will get closure of the DE junction. When you look at ablative, you extend that out by double to 48 hours if your zone of ablation is less than 500 microns. All of those are weird numbers, but they're clinically relevant because what will happen in those patients is whenever you get that DE junction that's not fully healed, you'll increase your chance of having hyperpigmentation or pigment dropout. So it's clinically relevant.
Now for a quick word from our sponsors. DermPub is the Journal of Innovative Dermatology. We are committed to promoting excellence in dermatologic care through the dissemination of cutting-edge knowledge and fostering collaboration among dermatologists, researchers, and industry professionals. We believe that by sharing innovative ideas and discoveries, we can collectively drive progress and improve patient outcomes. Contact thefutureofdermatology@gmail.com to learn more about DermPub. Want to be a sponsor of the Future of Dermatology podcast? We'd love to have your support. Contact thefutureofdermatology@gmail.com to learn more about getting your message in front of our audience. The Future of Dermatology is not just a podcast. It is a community of dermatologists who care deeply about your health. Have you ever wanted to produce your own podcast? OMG Media Outlet has all the tools and talents necessary to produce and promote your very own podcast, from recording to editing to publishing to promoting. They enable you and your podcast to shine while they do all the work. Contact Steph at omgmediaoutlet.com today to learn more.
Acne scarring is very common, and we know that from many of the old publications by Rebot-Halder, you do get actually deeper inflammation, particularly in African Americans as well as in Asian patients. So those are two patient populations that I see a lot with really significant acne scarring. And I agree with my colleagues that the first thing that you want to do is to treat the active acne. So I tell my patients, I'm not going to fill a hole while it's still being emptied out. And now we have so many more modalities to actually treat that active acne. And one of the safe ways that we can treat with non-ablative, if we're not going to do a one and done, and there are absolutely patients who are going to come and say, hey, I want one treatment and I want it done. Maybe I'm traveling here, or maybe I live somewhere else, you probably have a lot of those patients. But for traditional non-ablative lasers, and these were all of my original patients that we treated, so we can see her skin type 5 patient, I find that the temples tend to do really the best, no matter what. I'm not sure why, because again, there's no bony area there, but I feel like the temple is an area that does really well with treatment. And you can see here, this is about 1 month, and the patient still has a little bit of erythema, and the patients will have that. As long as there's not too much erythema. You'd mentioned about not treating with antifungals. I think the one thing that I would say is I also don't treat with antifungals, except if the patient has a lot of pruritus. I think itch is a sign that there may be a fungal infection going on. But this amount of erythema is absolutely normal. It's another patient of FITS type 4. You can see here that the temples tend to respond really, really well 1 month after treatment. Just some more photos, and these are again for non-ablative fractional 1550. This is a skin type 5 patient. What I like about this is you see that the patient actually has a little cherry angioma that also improved. So this laser is actually FDA cleared for the treatment of vascular lesions as well, because we know this is not selective photothermolysis. Blood is 80% water, so you can't damage the lining of that vessel. This is pretty decent treatment on the temple in a patient who's got mostly rolling scarring and a little bit of boxcar scarring as well. And you actually can reduce post-inflammatory pigmentation. So a lot of patients, like this patient here, who's a skin type 6, has post-inflammatory hyperpigmentation from acne. And as you treat the acne scarring and you fractionally treat and allow normal skin to reepithelialize, you actually can reduce your hyperpigmentation as well. Ablative lasers absolutely have a place for treatment. It's important to know that how aggressive you are with ablative lasers determines your downtime. So we see this patient here who had a low-level treatment, fractional ablative 10,600, in an area where he had some scarring. Not as much here. I think the jawline is an area where you can get into trouble with scarring. But in the temples where he had more scarring, we treated more aggressively. So this is a good way to see an internal control that areas that have higher density, higher depth, will have longer wound healing. And as a result of that, you can see that, he didn't have a lot of scarring in the other areas. We, again, didn't focus a lot in the perioral. He still has a pretty significant amount of edema and erythema just 1 week post-treatment. So it is important to know that, right? His erythema in the rest of the areas is pretty much resolved, but the erythema and edema here is still present at 1 week. And you can see at 1 month, most of it has gone away, and he does have a nice improvement and no post-inflammatory hyperpigmentation, but that's the main concern because you're taking longer to reepithelialize the skin.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.